Welcome to the first of two DPBS Early Career Psychology Research Award presentations. Just as a reminder, then the following one is tomorrow? The following Wednesday at noon. But today we are in for an amazing treat. It really is my absolute pleasure to introduce Dr. Rachel Radin, who's an assistant professor in our department, and is also a licensed clinical psychologist and does work and very important work within the eating disorders program. I have known Rachel for many years. She came to UCSF through NIH F32 to work with Alyssa Epple and Rick Hecht. She came in 2017 as part of the Center for Health and Community. And so at that time, the Center for Health and Community was at Laurel Heights. We were in kind of just a bunch of cubicles, and it was kind of a little bit dreary, right? It's like these gray walls, kind of office space kind of vibe. But Rachel really brought like this amazing energy. She has always been dedicated to rigorous science, and just her enthusiasm for doing the work was infectious. And so it was such a great addition to our small little team. And she's gone on to do amazing things, many of which you'll hear about today. She then went on to do a T32 postdoctoral fellowship through the Osher Center for Integrative Health, and then joined the faculty through K23 mechanism, so early career award. Rachel received her PhD in medical and clinical psychology at Uniformed Services University in Bethesda, Maryland, including a clinical psychology internship in pediatric clinical psychology at Mount Washington Pediatric Hospital, also in Maryland. Her research program is pretty remarkable. She certainly is a rising leader in the field of behavioral medicine, really integrating psychology, neuroscience, and metabolism to understand stress, mood, and mindfulness, and its role in eating behavior and metabolic health, as you'll hear about today. Her work really bridges important, rigorous clinical science and translational research with the goal of developing innovative and scalable interventions to reduce compulsive and stress-related eating. I have had the honor of working with Rachel as a collaborator. She is amazing. She works very hard and does top-notch work. And so I'm excited for her to share that with you today. And so we look forward to your presentation on the metabolic cost of craving. So please welcome up Rachel Radin.
Thank you so much, Eric, for that lovely introduction. It's really such an honor to be here today to speak with you all and accept this award. I also want to apologize as I'm getting over a little bit of a cold, so my voice is a little hoarse today. But I'm really proud and excited to be here today discussing research that I've been passionate about for almost 2 decades. My journey, I would say, as a researcher has been one of really excellent mentorship and just finding the right team of people who are similarly passionate about the work that we do in integrative health. You might be surprised to know that when I started as a postdoc, there was no funding available. The T32 funding had gone away, and Alyssa Epple was one of my, absolute research heroes, and I just wanted to find any way to work with her, to be in her presence. And so she really just demonstrated such excellent mentorship in helping me craft an F32 postdoc award that was funded on the first round. Those were different times at NIH, and it was really, even though it was a risk, it was one of the most valuable and creative experiences in forming my identity as a young researcher and clinician. And I really credit the fact that I found the right team of people with stellar experience, passion, and shared interest in integrative health. So that includes working with Dr. Ashley Mason, Dr. Rick Hecht, and of course, Dr. Eric Prather. So when I look at the trajectory of my career, it's clear to me that my research journey falls into 3 main buckets. So I started with this question about the biopsychosocial underpinnings of overeating drive or binge eating. It's a construct that I'll describe to you momentarily, and the mechanisms that really maintain or exacerbate it. So that was really a lot of my work in grad school and then postdoc. And then having a basis of understanding both the psychological and physiological factors that underlie this eating construct. And as part of my identity as a clinical psychologist, I turned to intervention work toward the end of my postdoc and into my faculty position and my current work. It feels really gratifying to be able to have both the clinical and research skills to tailor intervention work to meet the unique needs of a population that really, frankly, lacks good interventions and that faces both psychological and metabolic consequences of a highly stigmatized behavior. And then most recently, I've seen the power of public health approaches. To really strengthen and bolster some of the individual clinical work that we do. And so I'll also be talking about some of the preliminary combined environmental and behavioral health interventions in collaboration with a fabulous team at Sutter Health and within the public health department here at UCSF. And then I look forward to just talking about what maybe the next 5 years looks like. So I come from a graduate program, the Uniformed Services University in Bethesda. And for those who don't know much about this program, it was founded by Andy Baum and David Krantz, among others. And these are people who are very, very invested in the biopsychosocial model of health and behavior. And so essentially it was health psychology 101. We could not get away from incorporating some type of physiological outcome in our dissertation research. I'll have you know that I had the pleasure of doing hundreds of Trier social stress tests with children and adolescents and hooking them up to heart rate variability devices. So yeah, that was fun. But that being said, I really value as a clinical health psychologist the ability to understand individuals from multiple lenses and forms of study. And to understand the mind and the body is really a beautiful and transcendent thing. So I find this especially true in the field of eating behavior research, which is my chosen field of study, and something I remain really passionate about to this day. So why this work matters is that understanding how stress gets under the skin to disrupt eating and metabolic regulation is important because stress is so commonly tied to numerous health behaviors and increases risk for metabolic dysfunction if it's not intervened upon appropriately. So my goal has really been to, at my time at UCSF, understand how stress gets under the skin and how to break this cycle of stress and eating and negative eating behaviors. And so to really effectively impact obesity and related metabolic diseases, we need to address this underlying psychological driver referred to as overeating drive. So if I can convince you of anything today, it's that overeating drive is an extremely crucial yet overlooked or understudied behavioral target for the improvement of metabolic health. So I'll use some terms interchangeably here, but overeating drive or non-homeostatic eating behavior can look like stress eating or eating in response to acute stressors or in response to negative affect. And then the more severe kind of version of that is binge eating, which is technically defined by a loss of control over eating plus the consumption of an objectively large amount of food. And what we know cross-sectionally is that adults and children and adolescents as well who engage in binge eating in both general and treatment-seeking populations are much more likely to experience not only obesity, but also hypertension, insulin resistance, and the full metabolic syndrome. But perhaps most concerning is that even after accounting for the influence of body weight or BMI, this type of eating behavior can actually independently predict worsened metabolic health, including hypertension and the risk for type 2 diabetes. So why might that be? That was a question that I really wanted to be able to answer during my postdoc. Why might it be that this eating construct, even after you account for the obvious relationship between body weight and metabolic health, why would it be that this eating construct is driving some of these negative outcomes? And here's where the influence of acute and chronic stress comes in. So it's been well demonstrated that stress can promote negative affect, which promotes binge eating. And this has been demonstrated in ecological momentary assessment studies, as well as just anecdotal reports from many of our clients. And stress has lots of effects on our health when it kind of goes, unchallenged. So the psychological stress or threat response we know produces a high cortisol output. And having high levels of cortisol in our blood affects our appetite. So our desire for highly rewarding foods, such as foods really high in carbohydrates and sugar and fats. So it activates these reward processes and really creates this self-perpetuating cycle of stress, desire for reward, giving into that reward, lowering stress, and so forth. And it's this perpetual cycle of cortisol and stress eating that promotes things like visceral fat accumulation and other metabolic health outcomes that are concerning. So we've found some support for these theoretical models underlying eating behavior and health outcomes during my time here at UCSF. One of the things that I've been really interested in is exploring the impact of chronic stress on metabolic health and eating behaviors. And hair cortisol, which at the time was a new tool for exploring stress-mediated pathways, particularly chronic stress, was something that I had access to in one of Alyssa and Eric's fabulous studies, the SAGE study. And just by way of demonstration, hair, if you didn't know, cortisol is actually stored in the hair follicle. And we know that hair grows approximately 1 centimeter per month. And cortisol is accumulated during this process. So in theory, 1 centimeter of hair would represent 1 month of stress exposure. So we had the opportunity in this large observational study among high stress caregivers versus low stress caregivers to explore these relationships between chronic stress, hair cortisol, and metabolic outcomes. And after accounting for things like BMI, high stress caregivers relative to controls actually had lower cumulative hair cortisol over time, so at baseline and 2 years. So it was just kind of this blunted hair cortisol, which was counter to what I expected to see. And additionally, high stress caregivers, again, this is after accounting for the influence of body weight, showed significant increases compared to controls in terms of waist circumference and LDL cholesterol, or the bad cholesterol. And we also found that these high stress caregivers, who we didn't necessarily recruit to be high in things like binge eating or overeating drive, had higher reward-driven trait-like behavior at all time points. So regardless of baseline weight status, we found that chronic stress associates with reward-driven eating and predicts worsened health parameters. So individuals facing chronic stress may benefit from really tailored interventions that focus more on the regulation of stress and eating in tandem to prevent early onset of metabolic disease, regardless of weight status. Additionally, glucose likely plays a huge role in the maintenance of binge eating, but studies are limited. So what we know is that binge eating, the act of binge eating, impacts blood glucose levels. It triggers these rapid spikes in glucose levels, followed by elevated and sustained peak glucose levels. And it's these repeated fluctuations in blood glucose that can contribute to broader dysregulations of glucose control, including the development of type 2 diabetes. And so there's this appeal of using technology like continuous glucose monitoring to better understand and phenotype this eating behavior from a physiological model. And so even what I think is interesting with continuous glucose monitoring is that even those who might be considered normoglycemic, meaning that they don't meet criteria for prediabetes or full-scale type 2 diabetes, in a blood draw, so looking at A1C levels, that they actually can show fluctuations using continuous glucose monitoring that can indicate pre-diabetic and even diabetic levels at times. And really only a few studies now have examined CGM for binge eating populations. And we had the opportunity to also explore these relationships in a pilot study funded through the NORC among adults with overweight, half of whom reported at least subthreshold levels of binge eating. We first wanted to evaluate the feasibility and acceptability of using CGM technology remotely with participants over the course of 10 days. And we found it was very feasible and acceptable for participants to use. Excuse me. And we examined CGM and binge events over the course of these 10 days. And so what you'll see here in this graph is that on the binge days on the left versus the self-reported non-binge days, individuals experience higher glucose variability as that's seen in green here, area above the curve on these reported binge days versus the non-binge days. And so we also kind of tested out this model using time series analyses where we assessed the CGM patterns at about 2 hours prior to a reported binge event. And what was interesting is that we found that about 76% of binge events were correctly identified based on these CGM patterns that preceded the binge event. And so this kind of really refining and honing in on this technology and understanding what these individual patterns can look like can be used in the future towards these just-in-time adaptive interventions for binge eating by using wearable technology like CGM devices. So that's something that's really in its preliminary stages. I'll talk more about it in some of the intervention work later. But just to summarize, it's clear that binge eating and overeating drive independently predicts worsened metabolic health, which is likely due to chronic stress processes that maintain and exacerbate binge eating. Binge eating is both cross-sectionally and prospectively linked to metabolic disease. And both the physiological mechanisms of cortisol and glycemic control, which also affect the types of foods that are affected by the types of foods consumed in binge eating, may mediate some of these disease outcomes. I say this all to say that yet, oftentimes, what we see is that individuals who do experience significant binge eating tend to get referred to behavioral weight loss clinics because they're reporting that their primary concern is their weight, or their doctor or whomever feels that weight is really the underlying issue to address. But I would argue here that that's not entirely appropriate to really effectively impact obesity and related metabolic diseases. We really need to be thoughtful about addressing some of these underlying psychological drivers of overeating drive. And so the premise that stress, both acute and chronic, really drives eating behaviors and downstream metabolic consequences has been the underlying drive for most of my work to date, including some of the intervention work that I'm about to talk about. So I had the chance to explore this premise in a clinical trial at the Osher Center comparing mindfulness to standard behavioral weight loss program for adults with obesity. And what we found that baseline higher levels of binge eating versus, so again, these were all adults with overweight, some of whom reported binge eating. So those who were higher in binge eating at baseline appeared to show the greatest improvements or decreases in fasting glucose at 18 months, so a year and a half after the intervention, if they were randomized to the mindfulness versus the control condition. And this really suggests that mindfulness here may be a much better fit versus standard behavioral weight loss programs for people with binge eating. And then we also found that it was the decreases in binge eating at 12 months that explained improvements in both reductions in both weight and fasting glucose at 12 and 18 months. So I thought it was really fascinating to see that the effect of the intervention of mindfulness on weight outcomes explained through binge eating. So binge eating explained almost 33% of this total effect on weight and explained about 14% of the total effect on fasting glucose. So we found, I think this speaks to the idea that treatment type really matters, especially for those with binge eating, and that treatment mechanisms matter. So it was this promotion in decreases in binge eating that explained improvements in metabolic outcomes. And so why mindfulness? Why would mindfulness be an effective adjunct or alternative to behavioral weight loss programs? Well, we know that it promotes adaptive self-regulation, meaning how we react to stress. It helps us be more aware of our internal body states, our interoceptive awareness, feelings of hunger and fullness. That's really, it's all about awareness, essentially. And there's been quite a bit of research, particularly by my colleagues Jean Christeller and Ruth Bolivar, my K mentors, on the effects of a mindfulness-based eating awareness training program in reducing binge eating. However, there's been very little research that's examined these potential metabolic health, downstream metabolic health outcomes. And it may be just as effective as the currently existing gold standard treatments for binge eating, like cognitive behavioral therapy and dialectical behavioral therapy, but really more research is needed. And so as part of my work, as part of the a really fantastic study launched by Eric and Alyssa through the UC Healthy Campus Initiative, we wanted to promote overall wellness at UCSF among high stress, moderate to high stress employees here. And we saw the opportunity for a large scale study where we focused on a brief 8-week digital mindfulness intervention. And not surprisingly, we found significant reductions in all of these things like stress, job strain, burnout, depression, anxiety, and increased work engagement and reward and mindfulness. And this effect was seen even with just 5 minutes a day of meditation. And so we were able to really look at that data objectively from the Headspace app that we used, which was a whole other can of worms. But the surprising finding is that this study was among people high in stress, right? So we weren't necessarily recruiting people high in binge eating, but we did have measures of binge eating in there, thankfully, and we did see that the intervention did significantly reduce compulsive overeating when we looked at the red measure developed by Alyssa and Ashley, and we wanted to have a little bit more clarity around these mechanisms. So I've been working in mentoring Natalie Balin, who's at UC Merced. And we were trying to publish these really interesting findings that it was actually improvements in mindfulness versus reductions in stress below the PSS is how we measured stress, that were explaining the positive effect of treatment on reductions in binge eating behaviors. We also had a smaller study that was specifically tailored towards eating and weight concerns as part of this Stress-Free UC initiative. And again, we found reductions in perceived stress, but also reductions in waist circumference, which is one of the key metabolic factors of health. And this was in spite of no changes in body mass index. And so we really think that these mindfulness-based interventions, including digital interventions, have the power to promote metabolic health, including reduced risk for cardiovascular disease and or diabetes by virtue of these reductions in waist circumference. And it could have downstream positive effects on long-term health and longevity. And the benefit of digital mindfulness programs is that they're easily accessible and scalable method for improving health. And they can be tailored for other populations who experience stress, including those with binge eating. So we know that general mindfulness helps with reward-driven eating, particularly for those who meditate for at least 5 minutes a day. But I also want to present some data on motivational interviewing and posit that this could be an additionally useful approach for the behavior of overeating drive or binge eating. So we know that motivational interviewing is an effective adjunctive treatment for weight loss. Few studies have adapted it for binge eating, but there is some initial promise there, even with really brief MI. And some of the possible mechanisms of action are increasing importance, so increasing motivation for change, as well as increasing confidence or self-efficacy that one can actually make these changes. And so during my final year postdoc, I combined both the principles of motivational interviewing with general mindfulness and mindful eating techniques in this initial pilot study that was embedded within the Stress-Free UC Health Plus Health trial that I mentioned earlier. And we found initial feasibility for this combined motivational interviewing plus a mindfulness program in terms of reducing overeating drive. Participants, especially the ones who had high levels of baseline binge eating really reported liking the intervention. And so that was really the basis for my K award, where my goal was really to optimize and tailor the intervention specifically for adults with both overweight and binge eating. So enrollment for the study began in July of 2024. We've had incredibly successful, thanks to Isabella, our study coordinator, incredibly successful enrollment in this study. People are really interested in services. And we have pretty lax criteria for enrollment, where people don't need to meet full criteria for binge eating disorder. They can just have subthreshold binge eating. And we've randomized, these numbers are a little outdated, but we've randomized more than 50 people, half of whom have been allocated to the mindful motivation intervention. And then we're comparing them to an active control condition of just a self-guided digital mindfulness program. We so far are seeing really excellent feasibility and acceptability with this optimized intervention. Participants have been attending the majority of the doses of the intervention. So there's an initial phone call, a brief counseling session, and then 3 booster calls. These are all completed remotely, either through Zoom or phone call. Participants on average are engaging with the mindful eating online tools that we've developed at least once a week. We're still looking to look at compliance with the digital mindfulness piece on Headspace, which is a whole other can of worms, as I mentioned. That's taking a little longer than we had anticipated. But we see that participants report greater levels of satisfaction and credibility and expectancy in this intervention compared to the active control. And most importantly, we're seeing some initial promise for significant reductions in reward-driven eating in this intervention compared to the active control condition. And individuals who were randomized to mindful motivation are showing a trend for decreases in severity of binge eating, over objective binge eating episodes compared to those in the control condition. So pretty promising findings. And so the last few minutes, I just want to turn to kind of the final bucket of my research more recently, which is really bridging some of these biopsychosocial mechanisms to public health. And the idea that changing behavior by changing context can give you more bang for your buck here. So I had the pleasure of serving as a co-investigator on Dr. Alyssa Epple and Laura Schmidt's current RCT, multi-level RCT, that is looking at helping individuals reduce their sugar-sweetened beverage intake. So while it's not specifically related to binge eating, I think there are interesting parallels that can be drawn. And our team has initially tested out this light touch motivational interviewing intervention as part of a workplace that was embedded within a workplace sales ban on sugar sweetened beverages at both UCSF and Sutter Health. This was among employees who are reporting high levels of sugar sweetened beverage consumption. And this was both a combination of an environmental intervention, so meaning a sales ban of sugary beverages, plus some individuals, half of the individuals were also randomized to this brief supportive counseling program that was really just being pilot tested at the time. So there were really positive outcomes for people who had the sales ban plus the motivational interviewing intervention. All individuals reduced their sugar sweetened beverage intake and waist circumference. And there are particularly promising findings when it was combined with MI. What I think is most interesting is that the people who reported the most frequent sugar sweetened beverage consumption, so those people who were highest in cravings, also reported greater reductions in intake if they received motivational interviewing. So again, this speaks to this idea of tailoring intervention towards people who may need it the most. So this is a busy slide, but I just want to give you the overview of this cluster randomized trial among healthcare workers at Sutter Health that is currently underway. We're looking at 700 employees at 15 different Sutter Health affiliate sites. Half of the campuses are assigned to a sales ban, so a sugar sweetened beverage sales ban, and half are not. And then within each of those site conditions, half of the participants are randomized to a brief intervention, which I helped to optimize and tailor, and which was conducted entirely remotely, making it a more disseminatable type of intervention. And so we're assessing outcomes at both 6 and 12 months, including not only sugar sweetened beverage consumption, but also health measures like waist circumference and glucose. And I just want to point to some of the really exciting work that Isabella Fornell is working on right now, looking at the protocol, the intervention protocol that we designed and tested. And what we're seeing so far is that participants are reporting significant increases in motivation or importance for making behavioral change, and significant increases in confidence. And so we're really excited to see with the full RCT, when it is completed, whether these things are explaining our ultimate outcome measures. So in the remaining time that I have, I just want to point to some of my 5-year vision and some of the things that I'm excited to be working on. So I'm really interested in looking at mindful motivation in the workplace, adapting what we've learned from this Sutter Health study, and tailoring it towards individuals who have binge eating or subthreshold binge eating behaviors. And I'm really interested in combining both this individual level support through mindfulness and motivational interviewing and environmental support. So this could look like something like reducing access to some of the highly rewarding foods like ultra processed foods, which we know override the body's hunger and fullness cues and can contribute to dysregulated eating. This idea that, how can I work on my binge eating if the environment is presenting me with foods that reinforce the behavior, I think is something we should really pay attention to and be thoughtful about how we can set people up for success, particularly high stress healthcare workers who we know are a high vulnerability group. We know that they're high in chronic stress. We know that they report high levels of binge eating, and we know that they are at risk for poor metabolic health. And what we found from this study is that the workplace is a really efficient, scalable environment for testing these types of interventions. Employers are really motivated to address overeating drive to reduce healthcare costs. And so I'd be really interested in looking at insulin sensitivity and binge eating severity with a combination intervention. I'm also really interested in adapting the mindful motivation intervention for other groups, including emerging adults. So we currently have a study underway for graduate students who are also reporting stress and eating behaviors. And then as part of this study, we have funding to look at continuous glucose monitoring pre and post intervention. So I'm really excited to see what we find there in terms of glucose control. And then of course, I would be remiss if I didn't talk about, adapting this type of intervention once we have a full-scale RCT to see the effects. Adapting it for adolescents with subthreshold binge eating behavior, which is really, unfortunately, it's a highly overlooked population that we really need to target better, not just send them to weight loss clinics, and really be thoughtful about how we can best serve these individuals. And my work has been really enlightening at the eating disorders program with children and adolescents, figuring out how to best help these young individuals. So stay tuned. I just want to put a plug out for our current UCSF intervention. If you know of any graduate students at UCSF who would be interested, please feel free to spread the word. And then I also want to discuss this really exciting new clinic here that Dr. Nyasha Chagwadera has developed, looking at both binge eating and metabolic health. So it's really just a dream come true to see that there's a clinic that's dedicated to really targeting binge eating rather than specifically weight loss. And I'm really excited to collaborate with Nyasha on serving as a clinical psychologist in this program. So there's a little bit of information here about how to make referrals if you have adults. So far it's just adult clients, but if you have adult clients who are struggling with binge eating, please send them our way. With that, I just would like to acknowledge the generous support from the NIH, the UC Office of the President, and the NORC to complete the studies that I discussed today. And of course, none of these findings would be possible without the incredible team of mentors and collaborators at UCSF. at the Osher Center, at Sutter Health, particularly the Center for Health and Community, led by Dr. Eric Prather. In particular, I want to acknowledge the grueling day-to-day work of our wonderful CRC Isabella and our study therapists, Emily, Katie, and Olga. And finally, I want to just acknowledge those who inspire me day to day at the UCSF Eating Disorders Program. Your work really is stellar, and I hope to be able to contribute in some way in terms of intervention development for these folks. So thank you so much. We're still recruiting for our main study. If you want to spread the word, here's our link. And then with that, I'm happy to take any questions.
Hi, Rachel. Thank you so much. I loved hearing not only about your research, but about the journey. And I'm sure that inspired a lot of trainees in the room at a particularly tough time to be thinking about embarking on your research journey. So thank you for that. I wonder if you've thought about looking at your interventions and the research combining the psychological and the physiological work with people who are on GLP-1s or weaning off GLP-1s. That seems to be like a really rich area where people are seeking help to maintain gains.
Yeah, thank you for bringing that up. I think it's such an important question. You know, anecdotally, I'm just seeing so many, like from my clinical work, just seeing so many interesting and mixed, like a diversity of experiences on GLP-1s, particularly for those with binge eating. And so I'm really, just curious to understand the relationship with, you know, eating outcomes, binge eating, metabolic health, of course. And, you know, I'm sure it's not a one size fits all approach with medication, but I think with the clinic here that Nyasha has developed, we can start to answer some of those questions or start to kind of understand these relationships with GLP-1s. Yeah, and so I know many of the people who are probably coming to the clinic are in search of these types of medications, which could be really, really beneficial for reducing some of that food noise that is common for binge eating. Yeah.
We have a couple of questions online here. One is about some of the data that you showed. So the person asks, were the amount of minutes baseline at least 5 measured? And if so, who practiced more than 5 minutes? And did that have impact? How did that impact the results? So I guess this is about the Headspace.
The Headspace trial. So the question is, do we know who practiced the most?
Who are these people?
Who are the super meditators?
I'm also
in
this data, so I'm interested to know too.
Yeah, I'm curious what you were seeing. We unfortunately haven't looked at that yet, but I think that would be a great study to look at, you know, individual baseline predictors of treatment engagement. I would speculate that it's the people who have the most to gain from the intervention probably are showing the greatest compliance, meaning, and we see this with our Sutter Health studies. So the people who had had higher, subthreshold or high levels of A1C, meaning they were pre-diabetic, actually appeared to be the most motivated to make change in this other intervention. So I'm just extrapolating and thinking that perhaps the people who had the highest baseline levels of stress, like perceived stress, engaged the most with the intervention, or higher clinical concerns in general. But we know this was a high stress sample, so
a couple more questions.
Baseline predictors would be interesting to look at.
Rachel, that was so comprehensive. I just want to give you kudos for your multidisciplinary approach and carefulness and diligence. So my question is about threshold for stress versus trauma, like that range. And if you can talk a little bit about how you kind of dissect the pie in terms of efficacy based on stress level versus trauma level?
Yeah, it's such a good question. It's something that's coming up more and more in our current trial. And I really am upset with myself that I did not include a very good measure of trauma in the current the mindful motivation intervention, because what we are seeing anecdotally coming up with our clinicians is that, you know, individuals who do have this history of very significant trauma have a real barrier towards engaging with self-guided mindfulness approaches. Unfortunately, we have very skilled clinicians who work with eating disorders and trauma who are able to kind of adapt their approach. But I think that there has to be very careful adaptations made towards introducing a mindfulness program to this population, because there's a lot of concern about safety and can I trust my own body? Can I the idea that you can sit in your body and just be with it and present is very challenging for people, particularly for those with a trauma history. So I also think future work, we should really be very careful about that, if we include these individuals in future clinical work, you know, how do we make appropriate adaptations? So that's a whole other area that I'm learning more about. Certainly not my area of expertise, but I do think it's really important because there's such a overlap between binge eating disorder and PTSD and trauma history. Yeah.
Hey, Rachel, great talk. The whole time you were talking, I was like, oh, what about ultra processed foods? And then I, saw that you mentioned them on that slide. And I was so curious because I guess I don't know that literature so well, but I'm just wondering if that's maybe something you're considering adding to any of your more mechanistic studies, because it feels like in this very wild policy environment that we're in, there's actually some motivation to change food policy. And, I heard what you were saying about kind of the workplace and limiting access, but it also feels like it might be a time to just kind of consider, supporting limiting it, period. And I'm just wondering if, you've added anything to any of your ongoing interventions or anything like that to see if that might be part of the mechanism, linking stress to such poor health outcomes.
Yeah. So there's quite a bit of literature in the food addiction field that clearly shows that these ultra processed foods are tied in with binge eating disorder. And we know from this really cool study that Dr. Ashley Mason did, that when we asked people to bring in binge foods, we wanted to kind of elicit a real life binge episode in the lab, which obviously has its limitations. But I mean, not surprisingly, we found that the overwhelming majority of the food items people brought in were high in fat and sugars and ultra processed and all of those things. And so yeah, it's a tricky one, the food environment, and how do we target that more holistically? I think there's a lot of challenges there, but I think the first step would be starting small in an environment like a workplace where we've had a precedent for being able to enact environmental change, which is I can't even imagine the political drama that Dr. Schmidt had to go through to even get that sales ban to happen. A lot of people were not happy about it, and this is just about the beverages, right? So tackling the food is going to be an even bigger challenge. And so I think it's going to take a lot more work, a lot in partnership with people who work in the health policy field, and more understanding. But I think, the general consensus is that ultra processed foods are the things that are the most rewarding to us physiologically. And there's a lot of stigma attached to that when I think that there shouldn't be. It's a problem of I'll get in trouble for saying this, but it's a problem of the food environment that's available to us that maintains a lot of these unhealthy behaviors.
Let's do one online here. Deb Barnes asks or states, seems like there could be parallels with binging and other substances like alcohol and potential partnerships in the department. Have you considered that? Have people thought, oh, I should talk to Rachel about this? It's an open question.
Yeah, I'd absolutely be open to that. There's absolutely parallels. Yeah, particularly what we're seeing with the sugary beverage intervention. There are a lot of addictive-like processes that people are reporting that are maintaining that behavior. And that's where motivational interviewing, as we know, like started with the substance abuse world. And so we stole a lot of that, that great technique and adapted it to binge eating. So certainly there are parallels, and definitely always open to collaboration. So feel free to reach out.
Thanks so much, Rachel. So you and I have talked a ton about weight stigma and this work, and just kind of how, weight stigma, we know is independent predictor of negative health outcomes, both physical and psychological. And so I'm just really curious as we're thinking about this research and the different types of interventions that you're offering that maybe are a little bit different from, the typical behavioral weight loss model, like how you're looking at weight stigma in these populations and how it kind of manifests both in terms of engagement with the intervention and then also just thinking about outcomes as well.
Yeah, it's such a good question. And again, I'm kicking myself for not including a standardized measure of weight stigma or internalized weight bias. But it's so important to address. I think it's also important to address in more of these behavioral weight loss clinics too. In an ideal world, we would be assessing for binge eating, weight stigma, all of these things like across all clinics and figuring out, okay, what's the best strategy here? I will say anecdotally in our intervention, it comes up a lot, like unprompted during that brief counseling session when we're asking people to reflect on their eating behavior, what triggers it. It goes way back to, being young and internalizing this idea that, I cannot be in a larger body, or I have to finish all the food. There's also food insecurity piece too that we need to look at. But yeah, the idea that like I need to finish all the food on my plate, it's like another big theme that comes up. And I think just sitting with somebody and acknowledging it and like letting them share their story is an important first step. As I know we see in our clinic, and I think that's a real skill to be able to tap into that and understand some of the origins of the eating behavior. Yeah, sorry, I don't have a specific answer for you, but it's important. I agree. Yeah.
Thank you for the talk. My name is Descartes Lee. I was just curious about what your thoughts were about overlaps or collaborations with like Overeaters Anonymous or other kinds of self-help groups.
Mm-hmm. Yeah, I mean, we in the past have certainly reached out to those types of groups for individuals who might want to enroll in our study. I think it's interesting that a lot of the language in some of those groups is more about like food addiction. And I think that's a different construct than binge eating. Food addiction, like personally as a clinician, I have some concerns about that label, being addicted to a food, because like I said, it's the environment that oftentimes promotes these eating choices, and it puts a lot of blame and shame on the individual. So it's a long-winded way of saying I have some concerns about the label that's used in some of these groups as potentially being further stigmatizing. And that being said, I think a lot of people who report food addiction also have binge eating and can certainly, and they certainly have found support from these support groups. So I don't want to completely dismiss them. I think that they're an important resource, just as AA is an important resource for people with substance use disorders. Yeah.
All right, this will be you asking question. Last question.
Hi, that was a very interesting presentation. I heard you say something about Headspace being a can of worms, but I wasn't sure if that was the intervention you were using or what the mindfulness intervention was.
Yeah, so Headspace for my current trial is our active control condition. So we're comparing this active control of which is a self-guided mindfulness program, which we know has beneficial effects on eating behavior in general, to a more tailored intervention that combines both Headspace with this brief supportive counseling and mindful eating tools. So what I meant by that, and this is just kind of maybe a word of caution for folks who are engaging in the digital mental health field, or perhaps this is something you already know, but a lot of these apps are changing rapidly. And so the headspace that we use in stress-free UC is a completely different headspace now. So there's so much more content. We can't control the content, even though we are guiding people towards specific basic beginner level mindfulness meditations that we think could be really supportive. But when we look at the compliance data, we see that people are accessing everything, including things that are not necessarily, by definition, mindfulness practices. So that's what I mean by a can of worms. It's just a lot of sorting and categorizing that we are currently working to go through. So it's just harder on the research end to understand compliance. Yeah.
All right, well, we promised Rachel only 15 minutes of questions so we could save her voice. And so let's give her a round of applause for an amazing presentation.
Thank you.